Friday. How's everybody doing? Time is flying by. October 27th. Here we are. Insane. All right, cool. Let's get this thing started, guys. Good evening, beautiful minds. I'm Dr. Joaquin Acosta, your host and the proud CEO of PharmTrue, welcoming you to tonight's enlightening episode of the Know Your Pharmacist Livestream. As we traverse through dimensions of pharmaceutical care today, we unfold the pressing narrative of the opioid crisis. Our voyage begins with the proactive roles pharmacists now embrace against opioid misuse, transitioning into the digital realm where short-form video education is reshaping attitudes towards opioid overdose. As we delve into the heart of community engagement, we spotlight the National Prescription Drug Take-Back Day, underscoring the essence of collective action. The Herbal Wellness Corner tonight unveils the potential synergy of cannabis in alleviating the opioid epidemic, setting the stage for a broader discourse on alternative solutions. On the Community Spotlight, we'll navigate through the local endeavors supporting this cause, followed by a Men's Health Minute focusing on gender-specific substance use dynamics. Today is a blend of insightful dialogue, communal empowerment, and the relentless pursuit of knowledge. Special salute to our esteemed sponsors, PharmTrue, High Horse Cannabis Company, Vado Speedway Park, and the Baked Chicken Farm, who fuel this journey towards a better informed society. So let's ignite this conversation, enrich our understanding, and together, guys, contribute to a world where wellness prevails. Your engagement is not just valued, it's vital. So interact, share your thoughts, and let's make today's discourse a collaborative milestone. Now, without further ado, let's delve into our first segment, the Pharmacist Frontline. Stay tuned, stay informed, and let's weave science into community for a better tomorrow, guys. So jumping on into this, saw a great article that came out from the Pharmacy Times about the evolving role of the pharmacist in the opioid use disorder. And this has changed over time. And again, the term opioid use disorder, yes, I'm putting it in quotes because it's a devastating term to the pharmacy industry, because pharmacies, yes, have contributed to this, have caused this in many regards, been the ones that dispensed all the opioids that everyone got addicted to, right? So anyways, the big players in that, Walmart, Rite Aid, CVS, are having billion-dollar lawsuits and settlements that are forcing stores to close, that are causing big national issues there that are evolving out to where you're seeing things that we talked about like yesterday and a couple days earlier this week, pharmacy deserts, where the underserved communities there that are funded by government insurance such as like Medicaid and things like that, heavy populations in those communities are the ones that are truly not going to be served by pharmacies, right? Because again, those are the people who ultimately get affected. So where we're looking at opioid use disorder and pharmacies and pharmacists, guys, in the crisis where we're seeing right now in the pharmacy deserts, and the lack of availability of a pharmacist sometimes in some of the pharmacy industry, these are the things successfully that pharmacists are truly actually doing in the evolving role of pharmacists in opioid use disorder. So this brings up some talking points. I kind of wanted to shout out the article, talk along with it, shout out to the PharmD candidate and the doctor of pharmacy themselves that wrote the article here, and that came out today. But anyways, I thought there were some positive, very good points that came out of this. So look here. Societal harm brought on by the opioid epidemic is incalculable. 2021, 80,816 opioid overdose deaths in the United States. Because of their drug expertise and direct patient care, pharmacists are critical to addressing the crisis by both advocating for their patients and assisting providers. So it's a two-way street. Opioids have a long history of use, first positively documented in Mesopotamia, with ancient reliefs depicting Papaver somniferum, known as the opium poppy. It was valued for its analgesic and sedative effects. However, the roots of the opioid crisis lie much closer to the contemporary era. In the 1990s, drug companies falsified data and cited a high number of undertreated patients with pain to convince the U.S. Drug Enforcement Agency, the DEA, and prescribers that opioids were safe and effective. So That's where things started getting really, really bad. United States, notoriously, is consuming the most opioids out of any country in the entire nation. We're living them on the planet just the same as everybody else. We were coerced into this by the drug companies. Our own DEA was coerced into this by drug companies. Something not to be proud of, right? But where can pharmacists and where have pharmacists, been able to be a positive point in this intervention? Well, looking here, right? Traditionally, specialized clinicians have treated patients with opioid use disorder. So, you might think of like a methadone clinic, or again, other sorts of specialized providers there that are going to be treating opioid use disorders. How is opioid historically treated, right? Methadone clinics, as we talked about, 80 to 160 milligram daily is the mainstay of treatment. As a full mu receptor agonist, as the lowest withdrawal potential, alternatively a narrow therapeutic index as well, because of its high abuse potential. Difficulty tapering, overdose potential, complex dosing, and half-life of 12 to 150 hours. Next, right, buprenorphine, 8 to 24 milligrams daily, a partial mu receptor. Increase the likelihood of withdrawal. However, compared with methadone, buprenorphine has decreased abuse potential. I've seen people abuse it, though. People abuse buprenorphine, right? Improve treatment retention and improve outcomes. Buprenorphine, with its superior safety profile, is preferred for induction and maintenance. Recently, the FDA loosened buprenorphine prescribing restrictions to allow all practitioners with a DEA license to utilize it for treatment without obtaining X-waiver certification. Again, that X-waiver certification was an absolute pain in the butt for providers, for everybody to manage this, that, and the other. If the prescriptions didn't come in with the X number on it, it's technically invalid. You got to verify the prescriber has an X number and that it's valid so that they could prescribe like Suboxone, right? Or buprenorphine. So again, anyways, moving on. Naloxone, short-acting opioid agonist, uses nasal spray for overdose reversal, can be added to buprenorphine products. As I just said, Suboxone, that's the brand name of buprenorphine Suboxone combo products to reduce abuse potential because it blocks intravenous or intranasal opioids. People still use it to get high. Don't get that wrong, people. You can still literally abuse Suboxone. So again, another one that does not going to give any potential for abuse. This one, naltrexone at 50 milligrams daily, full mu receptor antagonist, has the greatest propensity for causing withdrawal if used for treatment induction. Has a high bioavailability, literally blocks all routes of opioid use. So with that one, right, you don't do it right away because, some people can be so withdrawn that it might like throw them into shock and kill them. And so the roles where pharmacists are helping to manage the medication, keep people safe there when it comes to opioid withdrawal, it is far and long. And not only that, but right, are pharmacists also the ones that are supposed to be identifying red flags for patients that may be trending towards opioid, abuse, and maybe their prescriber has misprescribed something out of the chronic pain guidelines, right, by the CDC, or acute pain guidelines from the CDC. And before they set those guidelines back in like 2018, it was out of control. When hydrocodone, Norco, before the Norco apocalypse, back in like 2014, Norco was Schedule 3. Everybody, was popping hydrocodone acetaminophen like candy, guys. Again, the United States felt any sort of pain, they were getting popped with Norco. And it made its rounds for a good while. And again, now it's Schedule 2. Pharmacists are following the CDC recommendations for pain guidelines, and pharmacies. I honestly credit Walmart Pharmacy with taking the first big stance against this. They were the first guys to actually get into honoring those CDC guidelines and making it part of their actual system of its processes to make sure to flag patient profiles who were doing over 50 MMEs per day, and have you called the doctor and followed up if they are out of the chronic guidelines. Exactly. So if you didn't have notes in the profile and you weren't doing those kinds of things, it was actually going to be a tick on your job. And again, that was a really good opportunity for that. I mean, with the New Mexico State Prescription Monitoring Program, that's a really it's another good thing too that is available for providers, so you can see where patients are filling their controlled substances throughout the state, and you can also look up other states as well. But it shows on what day they picked up, what controlled substance, how much they picked up. So there is a historical record. So you can monitor poly-prescribing or polypharmacies and things like that. And that's the role of the pharmacist on top of monitoring some of the drugs for those who are, trying to taper off opioids such as buprenorphine, naloxone, the ones we just talked about. So it's a big role that pharmacists really do play there in terms of managing opioids. And where we really only have 3 medications right now, guys, that are like standard for therapeutic, approval for opioid withdrawal. Like, I can't wait till cannabis becomes more of an option. That's basically exactly what I'm getting at. So anyways, pharmacists do play a really positive role, basically, is what we're getting at here when it comes to the opioid crisis. Pharmacies have been a part of the problem here in the United States. Systemic medicine and that part has been a part of the problem as well. But as well, we are also a part of our own solutions, and that's the good part too. So I like this article is well written and a good reminder there for the evolved role of the pharmacist on how that has become a problem. Really, the opioid epidemic, yes, it's been recognized, but truly, even since the CDC was putting out the chronic pain guidelines in 17, 16, 18, it wasn't being taught in schools that way. It was not, and it's just a fact. And there was just more gaps in the system. So we are still cleaning up a mess that we got ourselves into since the early 90s. And pharmacists are going to be a big part of that cleanup. Hopefully cannabis really is too. I really see some opportunity there. But from Pharmacist Frontline. Anyways, guys, moving on to our tech talk today. Interestingly enough, as we are on a live stream, for those of you who are catching this, looking at a study here, attitude changes following short form opioid overdose video education. So studying on opioid overdose response training and the need for its rapid expansion have become more significant as opioid epidemic continues to be a health crisis in the USA, limitation of funding. So basically, anyways, do you guys would you guys know what to do if you saw somebody overdosing on opioids? Even if it was, for instance, grandma that might have accidentally forgot that she took a pain pill and took one too many or whatever it is, or double the dose or something insane. I'm just saying, in that scenario, if you really did have that scenario, think about it. Would you be able to use the opioid fire extinguisher medication that should be administered with all opioid prescription medication? So there's no reason that somebody should be dispensed any sort of opioid medication without having a Narcan on deck, right? So you can have basically the nasal spray that will reverse the opioid overdose. So anyways, if you knew how to use it, how quickly could you learn? This study was kind of getting at that, and it demonstrated basically encouraging evidence that a brief virtual pre-recorded educational intervention improved participant-rated competence and readiness to administer intranasal naloxone in a suspected overdose. So again, yes, of course, people learn from this kind of stuff, but this is the kind of thing that, we sit here and we think it's kind of funny, but some people want to do Heimlich and want to learn Heimlich or whatever it might be. And nowadays, this might be just as important of a skill to have, right, as mouth to mouth, is knowing what to do in a crisis, right, in an opioid situation here. So looking at that, I'm going to show you guys a little video here, how to administer naloxone. Give me just a second. This is Sharon from the Idaho Department of Health. How to use naloxone. You may think you know how to do it, but do you? You know what I mean? Do you?
Injectable naloxone to reverse opiate overdose. Naloxone is a medicine and is also known as Narcan. When someone overdoses on opiates, they stop breathing. Naloxone reverses opiate overdose so they can breathe again. Opiates include drugs like heroin, methadone, OxyContin, Vicodin, Percocet, codeine, and fentanyl. Naloxone does not reverse overdose from drugs like cocaine, meth, alcohol, or benzodiazepines like Xanax or Valium. Step 1. How do you know if someone is overdosing? There are several signs. Not breathing, or breathing is very slow or shallow. Turning pale, blue, or gray, especially in their lips or fingernails. Making snoring, gurgling, or choking sounds. Becoming limp, throwing up, or not responding to yelling or other stimulation. The quickest way to see if the person is responsive is to take your knuckles and rub them firmly up and down the person's chest bone. If the person does not respond, check for breathing. Watch their chest to see if it rises and falls. Put your ear near their face to listen and feel for breaths. Step 2. Call 911. If the person does not respond and is not breathing, call 911 immediately. There may be complications that need medical attention, or the person may have overdosed on something besides heroin or other opiates. Emergency medical services are critical. Step 3. Rescue breathing. If the person is not breathing, start breathing for them. First, make sure their airway is clear. Check for food or anything else in their mouth. When their mouth is clear, tilt their forehead back and lift their chin. Pinch their nose and give them one normal breath every 5 seconds. Continue doing this for about 30 seconds. Step 4. Give naloxone. If the person is still not breathing, it is time to use your naloxone. If possible, use an alcohol wipe to clean the skin where you are planning to inject the naloxone. Remove the orange cap from your vial of naloxone. If you have a small 1 milliliter vial of naloxone, draw up the whole vial into a syringe. If possible, use a muscling syringe with a 1 to 1 1/2 inch needle that is 25 gauge or lower.
Usually is more covered
Insert
by
the needle
insurance.
at a 90-degree angle and push in the plunger. Inject the entire 1 milliliter of naloxone into their upper arm, thigh, or butt. Step 5. Give more rescue breathing. It may take several minutes for the naloxone to kick in. Brain damage can occur after 3 to 5 minutes without oxygen, so you need to breathe for the person until the naloxone kicks in. Give one breath every 5 seconds. If the person has not woken up after 3 minutes, give them a second full 1 milliliter dose of naloxone. Continue giving one breath every 5 seconds until they wake up or until emergency medical services arrive. Step 6. Follow-up. If the person is dependent on heroin or other opiates, they may go into withdrawal after you give them naloxone. Withdrawal symptoms can include vomiting, diarrhea, sweating, and agitated behavior. This may be unpleasant and dramatic, but it is not life-threatening and only lasts until the naloxone wears off. Tell them that naloxone wears off in 30 to 45 minutes and there are still drugs in their system. Within 90 minutes, the withdrawal effects will be gone. Watch the person for at least an hour or until emergency medical services arrive, in case they go back into overdose. When they wake up, keep them calm. Recommend that they seek medical attention and help them if necessary. Do not let them use more heroin or other opiates. The naloxone will block it and they could overdose again once the naloxone wears off. Recovery position. If you have to leave the person at any point, put them in the recovery position. Roll them over slightly on their side. Bend their top knee. Put their top hand under their head to support it. This position should keep them from rolling over onto their stomach or back, so they won't choke if they vomit. Prevent overdose. Opiate overdose is most common when your tolerance is down after you take a break from using, when you mix drugs, especially combinations of downers like heroin, methadone, or other opiates, alcohol, and benzodiazepines, when you've been sick, tired, run down, or dehydrated, or when you use stronger drugs than usual. To prevent overdose, go slow after breaks, or if you're using something stronger. Be careful when mixing drugs. Take care of yourself. Eat, sleep, and drink water. Review. If you think someone is overdosing, check for responsiveness by rubbing your knuckles hard on their chest bone. Call 911. Breathe for them for 30 seconds. Give a first dose of naloxone. Continue breathing for them for 3 minutes. Give them a second dose of naloxone if they have not woken up or started breathing. After they wake up, monitor them to make sure they do not overdose again. Put them in the recovery position if you have to leave. Refills. Ask your trainer how to get refills in case you use your naloxone and need more.
Same goes for the state of New Mexico on those sharps too. But cool video, guys. Hope everybody gets that. Why is it all relevant, guys? Tomorrow's National Prescription Drug Take Back Day. So what do pharmacists have to do with National Drug Take Back Day? Obviously, as the main facilitators in drugs, we do a lot. So again, people will oftentimes want to come to the pharmacy with big bags of drugs just to drop them all off because they say, I don't know what to do with these anymore. Really, in most cases, you're not allowed to take back any drugs under the law unless, right, you have a certain special permission under a license, right, to have a big DEA drug take back box basically in your pharmacy. There's 2 places here in Las Cruces that have it, the Walgreens and CVS on Main and Elks, both across from each other there. They have boxes, and when they get full, basically they get locked. But otherwise, they used to be at the police substations, and there's not a lot of places to go and clear your cabinets. A lot of the times, pharmacies will shoo you away. Sometimes pharmacists will do you a solid, which is not necessarily, may not necessarily be under the rules of the law there for them to help you get rid of it, right? Pharmacists do destroy drugs in nursing homes and facilities as pharmacist consultants, and they are the overseers of the drug destruction with a witness. Basically, so what I'm getting at here is pharmacists do play a really big role in that. And it's a big often question, especially when somebody passes away or, when changes are happening. Lots of times you will see, people asking, where do I take my medication? And it's a pain for them to figure out the exact answer because sometimes people know. Sometimes if you call your pharmacy, maybe someone will know where the resource is in town, or maybe it's just, a newer employee who doesn't really know, some of these questions to resources. So in terms of the role that pharmacists really play there, I hope, pharmacists, we are trusted healthcare professionals. I hope that we do play a good role in facilitating the initiative. Guys, in our community spotlight, we'll be spotlighting the places to get this taken care of here in Las Cruces. I already have posted those in here in the chat as well. So it's just kind of highlighting the importance of National Drug Take Back Day. It's an absolutely, important day, and we want to make sure that medication disposal, sharps disposal, that you guys are comfortable doing those kinds of things. There are sometimes packets and things that people can buy that can help you dispose of your medication by literally just putting water in it, and it'll pretty much make it dissolve and go away. But a lot of people don't have access to those. So unless you're getting the freebie packets at some sort of event, you're probably not going to have them, and they're not going to be given to you routinely. So again, it's not like it's not normal for you to have some stockpile of drugs, right? That may be in your grandma's home or whatever that might be. So again, as we talked about earlier, naloxone training, a life-saving skill. I hope you guys watched that video, saw basically a little bit about that. The immunization in the arm, or the injection in the arm. Naloxone is the one that we saw there. It's probably going to be the more common naloxone that you're going to be given generally, rather than the Narcan, which is the one that sprays in the nose, basically like Flonase. That one's a lot easier to administer straight up. But it's the same whole premises there. Anyways, always good to get walked through how to do it once. You know what I mean? Most people have been walked through it once, especially the ones that have been on chronic pain medications and things like that, and understand that. But new users, caregivers, friends and family, very applicable at all times for sure. So jumping over, guys, into our Herbal Wellness Corner, sponsored by High Horse Cannabis Company tonight. We are jumping into, again, going to continue to beat the drum on this. Opioids and cannabis, man, there's some harmony to be had there. And Dr. Dustin Suluk has really, really gotten into this, and I really just love this presentation. I'll keep showing it to you guys over and over in different nugs of it and all the best stuff. But again, what is he trying to attack, right? The challenges associated with prescription opioids, understand the evidence for using cannabis to treat chronic pain and spare opioids, describe clinical strategies for using cannabis medications to spare opioids, substitute the opioids, get rid of them. We have been hit with an epidemic of, the United States loved it fast and easy, right? We got fast food, we got big and fat, and we got, opioids being given out like M&Ms, and everybody's all of a sudden, what's the new problem? Everybody wants the fast, quick answer, and we're sold to want that. And now we have to reverse that, right? So anyways, the opioid problem. Can cannabis replace or reduce opioids? Does adding cannabis make opioids safer? Does cannabis prevent opioid tolerance and dose escalation? Can cannabis treat the symptoms of opioid withdrawal? Cannabis compared to other harm reduction options? How to use cannabis and decrease and discontinue opioids. Guys, so we've looked at some of the how-tos, initiating with the oils, doing the one-to-one CBD and THC separately, not going too heavy on the THC to spur, right, some potential other withdrawal activities or other potentials for abuse. Anyways, the big public health implications of opioid prescriptions. This is the nutshell. This is the great, bird's eye view for you. 46 people in the United States die every day from prescription painkiller overdose. 7,000 people are treated in emergency departments every day for using prescription opioids in a manner other than as directed. 1 in 20 people in the United States ages 12 and older use prescription painkillers non-medically in 2010. Sales of opioids quadrupled between 1999 and 2010. Between 2000 and 2014, the rates of death from prescription opioid overdose nearly quadrupled. What an attack. Enough opioids were prescribed in 2010 to medicate every American adult with a standard pain treatment dose of 5 milligrams of hydrocodone taken every 4 hours for a month. Wow. We think Albuquerque and Espanola are bad now. The United States was bad not just too long ago. Prescription opioids in America. While America claims less than 5% of the world's population, it consumes roughly 80% of the world's opioid supply. Let me read that again. While America claims less than 5% of the world's population, it consumes roughly 80% of the world's opioid supply. Is that not insane? That is distortedly insane. And we're paying the most for it too, on top of all that. If you were legally prescribed opioids in Mexico, you're paying cents on the dollar. And you guys know what American drug pricing is like. Anyways, Nearly 50% of the patients who took opioids more than 30 days in the first year of use continue to use them for 3 years or longer. Nearly 50% were only taking short-acting opioids, putting them at a higher risk of addiction. Nearly 60% of patients using opioids were taking a combination of drugs that are dangerous and potentially fatal. Prescription to heroin. Watch, 79% of heroin users report using prescription opioids before initiating heroin use. Well, do opioids help chronic pain? Evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. That's over 34 studies analyzed over 3 months of chronic pain and prescription opioids. No studies evaluated greater than long-term of 1-year outcomes related to pain, function, or quality of life. So nothing studied, right, really takes you out there. It was just some short-term hype, blow-up marketing studies, to really pump opioids into the hands of every single American. Talk about an attack. Increased risk for serious harms associated with long-term opioid therapy, overdose, opioid abuse, fractures, myocardial infarctions, and markers of sexual dysfunction, right? Looking at all of that, looking at the study, opioid versus non-opioid medication on pain-related functions in patients with chronic back pain or hip or knee or osteoarthritis pain. Opioids. Step 1, oxycodone, morphine or hydrocodone, acetaminophen. Sustained release oxycodone or morphine. Transdermal fentanyl. Step 3, right? Non-opioid group, APEP and NSAIDs. Step 2, nortriptyline, amitriptyline, gabapentin, which is getting a little more regulated now. Step 3, like pregabalin, like Lyrica, duloxetine, tramadol. Anyways, what does this study get at? No significant difference in pain-related function over 12 months. Pain intensity significantly better in non-opioid group over 12 months, right? Adverse medication symptoms were significantly more common in opioid group over 12 months overall, guys. So again, insane, right, for that. And you're looking at literally you're not even looking at cannabis yet, right? So looking over here at 11 random controlled trials published from 2010 and 2014, about almost 1,200 people meeting the inclusion criteria with excellent quality of trials, mean of 7 on the modified Oxford scale. 7 studies demonstrated cannabinoid analgesic pain controlling effect significantly better than the control. Drugs-related adverse effects primarily fatigue, dizziness, dry mouth, nausea, and disturbance in cognition, mild to moderate, transient, and generally well tolerated. Findings consistent with those from the previous review. Total of 22 of 29 RCTs demonstrating that cannabinoids demonstrate a modest analgesic effect and are safe in the management of pain. So guys, there is conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults. Cannabis as antiemetics, helping with nausea, helping you not throw up. Antiemetics in the treatment of chemotherapy-induced nausea and vomiting. Oral cannabinoids for improving pain, patient-reported MS, spasticity symptoms. Oral cannabinoids. Moderate evidence that cannabis or cannabinoids improve short-term sleep outcomes in individuals with sleep disturbances associated with obstructive sleep apnea syndrome, fibromyalgia, chronic pain, and MS. Guys, it's just insane. So we literally just told you and took you through how NSAIDs were better after a year than opioids at pain control. Opioids are inconclusive at even controlling pain long-term. Cannabis conclusively is effective, right, in chronic pain, antiemetics, MS, still moderate evidence, sleep outcomes. Again, and that has improved over time. There used to be not as much on the sleep, and there's still not enough to conclusively say it. That's why it's moderate, right? So cannabinoid and opioid synergy, you can use them together. Cannabis helps you take down your opioid doses, right? And how does that do it? We can look at all the meta-analysis and go through all this one by one by one. But again, I'm going to get to my humdinger of a part again because we've gotten there before. How to use cannabis to reduce and replace opioids. Take a small oral or oral mucosal dose of cannabis with every dose of opioids. Can be as little as 1 milligram THC below the psychoactive threshold. Even at low doses that do not cause impairment or adverse effects, cannabis can enhance the effects of opioid medications. Always use the lowest effective dose of cannabis to avoid building tolerance, right? You don't want the ceiling dose. If you're past that, too sluggish, too out of control, you're really just wasting your money at that point and ending up at a place that you don't want to be. You shouldn't be experiencing side effects from cannabis that you don't want to have. Anyways, use inhaled cannabis for breakthrough symptoms, severe pain, flashbacks, pain attacks, withdrawal symptoms, and to reduce cravings. Use cannabis to enhance essential health promoting non pharmacological activities such as savoring, exercise, meditation and prayer, journaling and reflecting, cognitive and behavioral therapies. All good things to do as you're trying to withdraw and taper off of those opioid doses. Step 4, use cannabis to promote regular sleep patterns, sedating strains only in the evening, oral delivery preferred. How to use cannabis to reduce and replace opioid drugs, select combination of CBD plus THC if available to enhance benefits and decrease side effects. Wonder-Wood ratio is broadly effective and well tolerated. Many prefer more CBD in the day and THC dominant at night, but this is highly individual. So, how to use cannabis to reduce and replace opioid drugs. Cannabis-naive patients are encouraged to take advantage of a 2-week window of opportunity after starting cannabis. Most patients reduce opioid dose by 50 to 80%. How to use cannabis to reduce it. Again, experienced cannabis users, there's a healer.com 6-day cannabis sensitization program before starting opioid taper and stay at the optimal dose. Again, that's saying introducing, that 1 milligram jumping in there. But guys, 50 to 80% reductions. I'll walk anybody through that any day of the week. And it's all personalized. Everything has to be specific to you. It can't be, just following some protocol, because no protocol, works for everybody the exact same way. So again, guys, DEA National Drug Take Back Day, Saturday, October 28th. Hope you guys go and clean out your cabinets tomorrow morning, 10 a.m. to 2 p.m. Here in Las Cruces, you can find it at the East Mesa Public Safety Complex, 550 Sonoma Ranch, or Walgreens on West Picacho, or Elks Lodge, between 10 a.m. and 2 p.m. That's our community spotlight today, sponsored by the Baked Chicken Farm. Thank you very much. Last thing we'll jump into for this evening, guys, sex and gender differences in substance abuse. So things that we may feel like we already know, but again, things to tailor the different thoughts there in the approach. Men more likely than women to use almost all types of illicit drugs, and illicit drug use more likely to result in emergency department visits or overdose deaths in men than for women. Illicit refers to use of illegal drugs, including cannabis, according to federal law, and misuse of prescription drugs. For most age groups, men have higher rates of use or dependence on illicit drugs and alcohol than do women. However, women are just as likely as men to develop a substance use disorder. In addition, women may be more susceptible to craving and relapse, which are key phases in the addiction cycle. So again, it takes, two to tango, and that's that person and that drug, whether it's men or women, right? But considering that not a lot of research has been done as to why men might be, more prone or not than women to abuse these things, I think, this isn't a blame game. It's just a conceptual point. But I believe that men are more apt to self-treat and self-medicate, and those are things that you can do to, in a man's mind, perhaps take care of it. And maybe that awareness there of not knowing when to go to the doctor and optimize your own health may be a little bit of a an oversight. But again, nothing to put on blame for. It's just maybe helping to better help people find where that line might be, so that maybe where a substance abuse problem could be just better healthcare in general and better health awareness. So I'll leave you with that on this Friday, October 27th. I hope everybody's had a fantastic week. It absolutely flew by, and we're getting into it. Have fun with all your Halloween preps and Halloween parties.